I now recognize Mr. Mfume from Maryland for 5 minutes of questions.
Thank you very much, Mr. Chairman. I want to thank you and the ranking member for calling this hearing. Director Welensky, thank you very much for being here with us. Just a couple of things and some thoughts and maybe one or two questions. We seem to always think about the pandemic as if it were some great big novel that had chapters that, as we read it, we knew what to expect. We did not know what to expect with this. We were operating in real time, and I've said that at each beginning of each one of these hearings. It's so easy to go back and to be a Monday morning quarterback or to claim to be doing the kind of investigative work that we are sure about the outcomes were. This was real. And the fact that healthcare workers have left in droves because we've bastardized what they've done, we've made them feel bad, we've deemed their efforts not worthy of what they should have done in our opinion, we've questioned their tenacity. We keep always making this reference to European countries without doing all of the proper research. I mean, the transmission rates in European countries were not apples to apples when compared with the U.S. It's important for us to say that. And I know it's novel and interesting and quick to be able to say, well, they did this in Germany, France, Sweden, et cetera. But just the fact that even in Sweden, as we just heard, infection rates for teachers were some of the highest rates that were being recorded. So it's oftentimes good to pump the brakes and to recognize that we were all fortunate enough to get through a very debilitating crisis as a nation, and that what we probably should be doing is looking to the future, not back at the past, because we've examined that 100 times to figure out if perhaps next year something like this happens again, what do we do and how do we do it? Director Welensky, I'm glad that you're here. I hope you use this as an opportunity to be able to express yourself in a way that you may have been constrained previously. We want to congratulate you on your work that you've taken part in and that you've led so many others in. Thank you for your accomplishments. I want to correct and affirm the record whenever I can. In your time as director of the Centers for Disease Control, you got it safe school openings of 100,000 schools and distributed the vaccine to 200 million Americans. And you've increased the aggregate number of COVID tests to almost 1 billion, funded medical research by directing your own budget internally to be able to do the things that were very, very important, and then put in place an organizational structure that's much nimbler with a greater response time. So we really should be saying congratulations from this committee. None of us had that task. We know we're all here now with the microscope, but when you're in it and you're in the ring and you've got to figure out what to do and you're being measured every day, it's a very tough job. I am particularly interested in your work to address disparate health outcomes and to advance health equity. We have seen among affected populations just all sorts of things that cry out for greater attention. And in your tenure as director, you established the updated Office of Health Equity. Is that correct? Thank you for that. And you led the development of CDC's new equity-centered data system. Thank you for that. And for the first time in CDC's history, you account now for social factors that have an impact on health, such as where people live and what's their income, what's their race, their age, their access to health care. Thank you again for that. Painfully, we've learned that during a public health crisis, we've got to be able to identify as well as care for the most vulnerable among us. And collecting and organizing that data will be critical, I believe, towards identifying vulnerable populations and ensuring their ability and to have resources and to thrive. I would ask you, though, if you could just take a moment in your own words and tell us what you think, quite frankly, are some of the things that we should be looking at as a legislative body. In other words, what legislation and legislative ideas would you suggest to this committee on the record that we perhaps could and should look at to begin the process of modernizing the country's data reporting system and how this change might, in fact, improve health outcomes for vulnerable populations.
Thank you so much for that. So much of what we are doing in CDC moving forward in our Office of Health Equity has been work that we can do internally, but we really do need your support. So for example, and I spoke a little bit earlier about our data systems, we have, data doesn't come to us necessarily with race and ethnicity data. If we can't see that those data that we have, or rural-urban data, zip code data, if we can't see where there are deficiencies, lack of access, lack of vaccinations that are happening, then we don't actually know where to tailor our efforts. There are two things that need to happen in that regard. One is we have to stop using fax machines to get data to CDC. We need resources for data highways so that, and many of those resources are going out to jurisdictions, 3,000 jurisdictions reporting data to us. If those data highways are flowing, then we can actually receive the data and give it back so that County A knows what's happening next door in County B. It's also the case that we don't have the authority to, we act voluntarily, receive data voluntarily. That means it comes in non-standardized fashions. It doesn't come in with all of the information that we want. The example in the Mpox outbreak is we didn't know the race and ethnicity of people who are getting Mpox or people who might have gotten the vaccine. Were we actually matching the vaccine with where the cases were happening? So we need some data authorities so that we can act nimbly and so that we can actually intentionally put resources where they are needed. The other is our workforce authorities. We've talked a lot about the attrition in public health workforce and healthcare workforce. Tax-exempt loan repayment, for example, direct hire authorities, fellowship hire authorities, danger pay, the fact that we have people in Ebola-stricken nations working but not receiving danger pay. These are all some of the authorities that a nimble, response-based agency should have.
Thank you. My time has expired. Thank you for your work.
Thank you.
I now recognize